Start off with the workshop right away. So Dr. Sumit is doing the first workshop. I request him to start off. Thank you so much. Have a great day. Be free to reach out if you require anything at all. We're just in the next hall. And during the inauguration time, requesting all of you to come to that side as well. Thank you. All of you can come forward. I think it's a workshop. You can come to the front rows. You can make it more interactive. Yes. You can also have a word with your friends, put in the groups and all that, so that they can start coming at least now. Yeah.
Yes, this is regarding Dr. Sumit Gupta. Dr. Sumit Gupta did a master's in sports. Dr. Sumit Gupta did his master's in sports physiotherapy at Amritsar, diploma in osteopathic manual medicine from Japan, working as principal of Santosh College of Physiotherapy. He is also a visiting consultant physiotherapist at Fitbill's Sports Performance Center and also been official physiotherapist of FC Barcelona Camp 2012, 2013 and XIX Commonwealth Games. We welcome you, sir.
Hi, good morning. I think everyone is sleeping at home only, they want to come later. But I want to see some, foreigners lectures, that's why I told keep mine morning, so I will finish and then go. So what is the topic today? It's rotator cuff related shoulder pain. It's a very vast topic. So if you see, normally it takes 1 day properly if you want to understand about that. So I have to concise it to at least 1.5 hours, try to finish as much as useful information for you people. So as it's already 15 minutes late, so we'll start, we'll not talk much. So what we are going to discuss today, in just an overview about that, just a brief introduction about little anatomy, little biomechanics, then what is rotator cuff related shoulder pain, then how we can explain in a simple term, because patients are going to ask you, what exactly happened to me, what you are telling about rotator, they will not understand that. So it is just in a simple term, what you can explain to your patients, what is exactly rotator cuff related shoulder pain, then how to assess that. There are different things, and different assessments. So whatever is evidence based, that I have taken from lot of researches, all these things. So assessment related to that. Then what are the conservative rehab options? As a physio, first we should try conservative. But there are some patients which can't be improved with even conservative rehab. So how we have to go next? What are the patients we have to send for surgeries, like a decision making? What are the criteria for that? Then post-op, how you can plan on what type of patients, what type of rehab after surgery has done, what are the points you should note down, then rehab, following rotator cuff repair. So as, shoulder, you will see mostly it is the third most common, musculoskeletal disorder, as you will see in orthopedics. It is in the world, it is not only in India. It is the most common, joint which gets more prone to injuries. And lifetime prevalence of shoulder pains, it is 66.7%. And in that, even some patient doesn't require any treatment, they recovers by themselves, but that considered only 10%. Or with some simple exercise, home exercise program, they will recover that, but that only out of 66.7 point, that means only 10%, not that. About 40% patients continue to have pain. And they require, even after 1 year of physiotherapy, there are patients who doesn't want to go, some surgical or something, they still want to try physiotherapy. But you don't have options sometimes, you have tried lot of things, even after 1 year, still they have pains. And in that shoulder pain patients, only rotator cuff related shoulder pain, accounts 60 to 70%. That means it's a lot of patients you will get rotator cuff related shoulder. In our, mostly OPDs, you will see mostly shoulder patients only daily basis 30 to 35. And what they have found, rotator cuff related shoulder pains, it is not only, okay, the patients like who is doing some activities or some heavy load workout, all they will only get. Even the patients who is having some cardiometabolic risk factors, they are also prone to rotator cuff like shoulder pains. So whenever you are mostly checking the patients, you should also check these points. Might be the patients have these cardiometabolic risk factors, so you can send the patients for these tests also, like glucose, that means HbA1c test. You can check the hypertension, you can check central obesity, cholesterol levels. If they have this, mostly your rehab is not going to work 100% if you do only exercises. You have to consider these points also. Now just a brief anatomy. So from the point of osteology, so what is the mostly everyone thinks rotator cuff related shoulder pain, and this is your humeral head, and this is your glenoid. So that's it. This is the space is reducing, so you are getting rotator cuff related pain. So that's why everyone thinks the crime scene is this. This is not at all. And the lot of studies has proved this is not due to compression of the structures only in between the acromion space and the humeral head. Then from the muscular tendons point at we know the important structures in the shoulder dynamic, that is rotator cuff. So what is happening? Rotator cuff, giving name only rotator cuff means rotations, which is causing so this is the main structure which is related to rotator cuff related shoulder pain. That's why, and there are 4 muscles. Mostly every physio knows this. This is not new. So you should know what are the 4 muscles included in that. So all these muscles originate at the scapula, inserts into the humeral head. However, when we are discussing mostly rotator cuff related shoulder pain patients, it is not only rotator cuff which is maintain the stability and mobility of the joints. There are large group of other muscles also, like triceps, deltoid, pectoralis, and all the scapulothoracic muscles like trapezius, serratus anterior, levator scapulae, rhomboids. These are also mostly important to maintain stability and mobility of the shoulder joint. So it is not only rotator cuff. Rotator cuff is the main, but that without other muscles, you can't maintain the mobility and stability in the shoulder. So just a brief about important kinematics about glenohumeral joint. Glenohumeral joint has mostly 3 movements, flexion, extension in the sagittal plane, frontal plane, abduction, reduction, and the transverse plane rotations. So mostly if you see the arthrokinematics, there are 3 types of movements which can cause mostly spinning, which happens in the flexion extension, and the rolling and gliding, which happens in the abduction reduction, and the rotations, again the gliding and that. So we can't go deeper about this because we don't have time to go for deeper biomechanics. So then the scapulothoracic joint, it is not a true anatomical joint, it's a functional joint. So which forms between the scapula and the thorax. So any movement which is happening in the scapulothoracic joints, that means it is along with the sternoclavicular and acromioclavicular joint. So both all these movements are interdependent with each other. That means any movements, elevation, depression in the scapula, it is happening, the clavicle will also move along with that. So this is very important things because rotator cuff related shoulder pains mostly related to this. So that's why you should know these movements when you are treating the rotator cuff related shoulder pains. So there are 6 primary movements which you can see in the rotator cuff scapula. One is depression, one is elevation, then the protraction, then the retraction, and then downward rotation and the upward rotation. So other 2 types of scapular motions also happening, but which you can't see from your eyes. That is very difficult to observe that, but that is also happening inside. So based on the research, that movements they have found which you can't see, that is causing the rotator cuff related shoulder pain more. So as you can see in the first picture, you can only see the downward upward rotation from your eyes, but you can't see the external internal rotation which is also happening in the shoulder scapula and the anterior and posterior tilt. So these are the studies which has done scapular positions. Disorders are frequently associated. They have found mostly in 80% cases rotator cuff related shoulder pain, scapular positions, mostly malpositioning of the scapulas. So even the Styref has done the study in 2011. What they have found, posterior tilting and upward rotation of the reduction in patient with rotator cuff related shoulder pain. So that means which I told you, the posterior tilting. That means this the movement which you see the spine of the scapula, it's not tilting backward. That there are a lot of factors that we are going to discuss why it is not tilting backward. But these two movements and the scapula external rotation, which you can't observe from your eyes, but that is not happening. That is the reason mostly they found that with rotator cuff related patients, this is the most thing which is happening. So rehab has to be designed this type of things. So just the main thing, the force couples. There are two types of force couples which is happening in the shoulder joints. One is the deltoid and the rotator cuff force couple. One another is scapular force couples. What is the deltoid force couple? Any model? Model? No, it's okay. I can show in this also. So what is the deltoid force couple? Just in a simple term I'll explain you. As the patient is doing abduction, so there is a superior migration of the humeral head is happening. So this who controls? The rotator cuff. Otherwise you can't control the deltoid force which is taking the humeral head upwards. So how this controls? When you're taking this like this, the rotator cuff muscles pulls this inferiorly by pushing the humeral head into the glenoid fossa. That means centralization it is happening. So this is the reason your shoulder kinematics maintained properly. If this is not happening, that means you can't maintain. Then the another force couple which is also important, as I told you, the scapular malpositioning is very important to maintain for the any shoulder mobility and stability. So the mostly if you see, this is the rhomboids muscle, big muscle, and this is the levator scapulae muscle which attaches to the transverse process of the C2 to C5. If that goes for tightness and the rhomboids goes for tightness, so it will be happening like this. That means your scapula is not able to move upward, and it is not able to translate that external internal rotation which is happening. It's not able to do. So then even when this is tight, the serratus anterior goes for weakness and the lower traps goes for weakness. So these two muscles are not able to take the scapula upward, and these two muscles are maintaining the tightness. So that's the reason this Morse couple also very important to maintain. So whenever you're making your rehab, you should check these rhomboids are getting tight, it's lengthened properly, the levator scapulae is tight or not, or the serratus anterior weakness is present, lower trapezius weakness is present. So this is very important to maintain the scapular muscle force couple. Thanks. So another study done by Styref in 2014. So in rotator cuff related shoulder patients only, so shows reduced activity of serratus anterior and lower traps and increased activity of upper trapezius, as I already explained you, because of tightness in that. So it is not able to do upward rotation because of serratus anterior weakness and lower traps. So now comes to what is rotator cuff related shoulder pain mostly. So it is given by Nair, and that's why it's called Nair impingement test, all that. So he has given the definition, which is mostly these days it's not valid because there are a lot of mostly controversial studies which is they are telling it is not happening. But okay, as he has given the first definition, I just explain you what is that. Okay, the main clamping of fine deep muscles. That means the rotator cuff is compressing due to reduction in the subacromial space. Okay, that is what. So from thereafter, every physio is trying to increase the space only. That's why the name also given shoulder impingement syndrome. Okay, but this is not a valid name now for the rotator cuff related shoulder patients. So it is not due to compression of the structures. There are studies which is might be, if you take 50 studies they have done, in that only 10% are saying it might be not. But that is controversial. It's not have good evidence. So there are contributing factors. That means rotator cuff related shoulder pain, it is not only due to subacromial space reduction, all that. It might be not, but there are other factors, so which can cause this. That means the rotator cuff muscle overuse, the instabilities and movement disorders of the scapula. So mostly, all the studies has found movement disorders of the scapula with the rotator cuff related shoulder pain patients. That's why the scapula is very important to train and rehab whenever you're treating the rotator cuff related shoulder pain patients. So as I already told you, it is not only due to compression of the structures in between the subacromial space. That's why it is a heterogeneous syndrome. It is not a homogeneous syndrome. Heterogeneous syndrome means lot of factors which is causing that. It is not a one single factor which is causing the rotator cuff related shoulder pain. So as you can see in this, so normally how much is the subacromial space when you do elevation from 120 degree to 0 degree. So when you do 120, sorry. So when it is 120 degree, the normal space which everyone has, it is 4.8 mm. When it reach to 90 degree, it is 5.7 mm. When you reach to 60 degree, it is 8.1 mm. And when you reach to 0, it is 11.1 mm. They have studies, everyone have this. So when it reach to what they have found in some studies, 2.9 mm with the patient who is having rotator cuff related shoulder pain. But they have worked on the scapula and that space has increased after that. That means it is not due to compression of the rotator cuff which is causing that problem. It is in the scapular movement disorders which is causing that space. So there are other things also which they considered, the shape of the acromion. It can be flat, it can be curved, it can be hooked. There are 3 types, but mostly they have found, the hook shaped mostly considered to the, rotator cuff, tears or rotator cuff impingements to develop all that, But again, so what they have found in strong evidence is still lacking. This is the cause which is causing that. Because if it is causing, the tear should be on the bursal side more. Tear should not be on the other side, which I was going to discuss later. Because the most of the tears which you found, that is on the articular side. That is not happening on the bursal side more. So that means strong evidence is still lacking. Acromion shape and also can cause this or not. So you can see in this picture, the red color, it's the bursal side arrow, and the arrow which is showing, the green, that is the articular side. So articulars, what they have found, the articular side tears are mostly common, compared to bursal side. So that means the compression, it is not at all happening under the acromion. If the tears has to be happen under the bursa more, if it is related to subacromial space compressions, all that. So even there are some studies which has done even the surgeries, subacromial decompression surgeries, it is mostly placebo. It is not correcting any anatomical or pathological structure, it is just a placebo. But if you have tried the physiotherapy already, you are not getting any results. That means what is the option? You have to send for these things because the patient want results, pain relief. So that means failure of conservative management leads to surgery. But they have found this even after surgeries, it might have benefited to some patients because of placebo effect. So as now, how we can explain rotator cuff to related shoulder pain to our patients? Okay, you can't tell, okay, the patients, okay, just this is happening all anatomical way, all pathological structures. They won't. They want simple terms. What is happening with me? Okay, so you can explain that patients, just your pain probably coming from your muscles and tendons in around the shoulder joint. These lack capacity. When you are lifting your arm, leads to pain. Lack of capacity means lack of endurance, lack of strength, lack of flexibility due to overload, and pain arises. Okay. So this is very simple term you can explain to your patients. They will understand also that, and rotator cuff related shoulder pain patients doesn't require any imaging if you do the assessments proper. Okay. So that means if you explain this to the patients, but criteria has to fulfill, they are exactly fitting under rotator cuff related shoulder pain. Now comes to assessment part. So first, going to assessment, you should know about red flags. Okay, you can't okay, go with the rotator cuff related shoulder pain patients without knowing red flags. Okay, so tumor. Okay, how you get to know the patient is having tumor? Okay, might be they are having unexplained weight loss. Okay, history, unexplained fatigue. They have, okay, swelling, mass present in the body. Okay, deformity is there, and so might be, okay, some patients when you're doing the mechanical stresses, it is pain is not related to mechanical stresses. You can consider these things. Okay, so that means that patient is not fitting your criteria to diagnose, to go for physical examinations, all that. Okay, then fracture or unreduced dislocations. That means the patients who has any significant trauma, okay, or loss of acute motion. These type of patients might be due to seizure. Okay, some patients have seizures. I have seen that some patient came seizure. Next day they were complaining about pain. Okay, so we have, after that, when we checked the history, all that, I have sent him for X-ray. It was, okay, anterior dislocated. Okay, which got reduced, but still the pain was there. Okay, so these type of patients, it's a red flag for, okay, physiotherapy assessments. Then neurological lesion, that means any unexplained sensory or motor deficit. Okay, so these type of patients also not fitting into, okay, your criteria to assess. Then visceral pathologies, patients who comes to you like, okay, I have, okay, scapular pain from, okay, 4-5 days. Then you have to take history, what has caused that. Okay, so it might be, sometimes studies has found it, even ingestion of fatty foods can cause your medial scapular pain. Okay, so any pain which is associated with gastrointestinal symptoms, that patients also, any patient who is pain is developing after any physical exertion or respiratory stresses, or even mechanical stresses is not correlated with your pain. So these patients might have some visceral pathology. So this is criteria for red flags, not to assess the patients. Okay, send it for further evaluation. Now, rotator cuff related shoulder pain patients, what are the main signs and symptoms you will see in these type of patients, which gives you idea. Okay, you can go for further evaluation. Pain over deltoid and upper arm region. Pain specifically when you moving your arm. Pain in overhead movement and reaching behind back. Pain lying on affected shoulder. So these symptoms can mimic to others also, but we have to do differential diagnosis also further that. Okay, but this will give you idea. Okay, exactly the patient is at least sign and symptoms. Okay, first you are getting idea rotator cuff related shoulder pain is present or not. Then I told you, because these symptoms mimic with lot of other conditions in the shoulder. So you have to rule out okay, other conditions also like AC joint injuries, slap tears, long head of biceps injury, large rotator cuff tears, even the pain coming from cervical origin, trauma. Okay, so these things you have to rule out. Now I will get just brief about what are the differential diagnosis points you can note down when the patient you are assessing with rotator cuff related shoulder pain. So mostly AC joint injuries comprises of 9% shoulder injuries and it is mostly you will see the patient coming with after trauma, sports injuries or patient have arthritis. So as I told you, symptoms will mimic like rotator cuff related shoulder pain. But what is the difference? This mostly cause after trauma. Okay, when the arm in abducted position. So adducted position. So patient will be like in sports. What is happens? The patient while playing, they fell down like this. Okay, so arm in adducted position and they fell down on the floor. Okay, so that is the main. You will get the mechanism of injury when you ask the patient. What was the position? How you fell down? This gives you idea. It might be not related like cuff related pain or it might be AC joint injury. So sign and symptoms mostly mimic. That's why you have to do one cross body adduction sign also. It is a test also. You just have to tell the patient to do cross body adduction. If it is giving you pain, you can suspect AC joint injury also. So pain, only difference is in that the lateral side pain will be more in rotator cuff. In this top of shoulder also will be paining. And it can radiate to anterolateral neck also and supraspinatus muscle also. Now comes next slap tears. Slap tears mostly you will see in overhead throwing people. It might be in sports, it might be overhead working people, whatever mostly happening in abduction and external rotation position only. It won't happen in other positions. Easily you will not find out this slap tears. So in this there is loss of motion only at the end range. When you do, mostly it is over pressure like. When you do, then only they will have pain. In normal day-to-day activities, they will not having pain at all. And dead arm syndrome symptom will be there. That means where velocity and accuracy of throwing action, they will not be having proper. They will feel like I am not able to generate force while doing this action. That is there. They will feel like my arm is getting dead in this. Other all movements are normal. But when I am doing this and trying to generate force, I am not able to do. So feeling of dead arm syndrome. Special test, mostly there are a lot of tests, O'Brien test, biceps load test, but all lack specificity. It is, you can't diagnose with that test. So what is the option to diagnose this? Even MRIs will not show. MRI arthrogram only will show you the best choice for if you are suspecting slap tears. Don't send for MRIs, send for MRI arthrogram. You will get clear picture of that. Even MRIs will have mostly not able to, even the radiologist will not able to see clearly that. Now the long head of biceps injury. Long head of biceps, mostly what is the function? It is very little function in mostly only in abduction when arm in external rotation. So anterior onset pain radiating down to, that means this area they have pain. Long head of biceps pain, mostly they have history of involvement overhead activities. The patient who have long head of biceps injury, they will give you history of overhead activities mostly. Special test, so this has very good specificity and sensitivity. It is mostly 79% has sensitivity and 73% has specificity of this test. Just one model. So as what is the special test? It is uppercut combined with palpation. So what is uppercut? Why they have given the boxing? It's like a boxing punch. So this is the uppercut position. So you have to tell the patient make the arm into slight abduction, then supination, and tell the patient to do a quick movement. Just go into, it's a quick, it is more fast, it is like this. If they feel pain, in the biceps area, that or some click in the biceps area, that means the test is positive. It is not, okay, slow. If you tell the patient to resist like this, just resist. It is not this test. Okay, it's a quick reaction. Okay, so this test is a very good test to diagnose the long head of biceps injury. Then the large rotator cuff tears. Okay, this is also you have to exclude and differentially diagnose. So before going to rotator cuff related shoulder pain patients. Okay, so small partial tears can, okay, comes under rotator cuff related shoulder pain patients, but large tears doesn't comes under that. That's why you need to exclude the patient is having small tears or patient is having large tears. Okay, so when you're I will go to after that how to diagnose large tears. So when you're suspecting large tears, there you require MRIs. There you can't go with the just special test, all that. Then you require MRI to rule out, okay, it is large tears and how much the size of the tear. Okay, and large tears mostly affecting 40% of the population you will see who have shoulder pain. In that 40% have only large rotator cuff tears. So it is very common. That's why shoulder surgeons are very happy. They will get lot of patients like this. Okay, their OPDs will be filled with large rotator cuff tears patients only. So large rotator cuff tear patients, pain mostly you will see anterior and the late anterior side. They will complain mostly here, and the pain will be constant. It is not like the rotator cuff normal partial tear patient. They will not be having constant pains, or even they will be not having night pains. Okay, but these type of patients, they have constant pains and night pains. Mostly sleeping on the same shoulder, it will increase night pains also, and along with that they have weakness component also. In small tears, the weakness component will not involve much, but in these type of tears, weakness component also involved. Okay, so they will not be able to do inability to raise. That means whenever they are lifting, they will be lifting like this. When you tell them to lift, they will be lifting like this. They will not able to, okay, take the up. What is happening? The deltoid force couple is gone in this. That means dysfunction is happening in the rotator cuff. That's why they are not able to do it. So humeral head is going into superior migration. So this is a sign of, okay, you will see whenever the patient is lifting like this. Okay, not after surgery. Even after surgery, patient will lift like this. That will explain later. Okay, so before surgery, if the patient is coming to you and you tell them to, okay, lift the shoulder, but they are lifting like this, they are not able to do. You can suspect that time they might have large tears. Okay, so even the large tears patients, scapular disc studies has proved scapular dyskinesia you will see in mostly large tears patients. Then they will feel pain in anything pushing, carrying activities and overhead activities. Okay, so most of the activities in day-to-day ADLs, they will get pain only. And special test like drop arm and external, okay, lag sign will be positive. One model. Can anyone other one can? So first I will show the drop arm test, then I will show the external lag sign. So what is the drop arm test? Okay, you have to tell the patient, okay, passively you have to take the arm to 90 degree, okay, externally rotated, okay. Then you have to tell the patient to hold the arm, okay, and bring it slowly down. But what happens with, okay, the patient who have large tears, they will go like this. They will not able to control it. Okay, so if you tell them to bring it down, they will not able to bring it down easily. Okay, so mostly it fell down from 90 to 80 degree. It goes like this. Then they might be able to control. Okay, so this is a positive test. Okay, if you have large rotator cuff tears. Another test called external lag sign. Take the arm, okay, into external rotation passively. The patient who have large rotator cuff tears, they will fall back 10-20 degree. Okay, automatically. They will not able to control here. It will be going like this. Okay, so these two tests, if it is positive, and this has very good sensitivity and specificity also. So, but along with other tests, okay, if you do along with MRI arthroscopy, it gives you clear picture, okay, of that. But these two tests you can definitely do when you are suspecting large rotator cuff tears. Thanks. Now comes to, specific physical examination. Now we have done differential diagnosis. Now we'll go to specific physical examination to exclude frozen shoulder, to exclude cervical origin pain, pain secondary to trauma, and the rotator cuff related, we have to provoke the symptoms now if the patient have rotator cuff related shoulder pain. So first, to exclude frozen shoulder, what is this? It is spontaneous onset. So patients also don't know what is happening inside. Suddenly the pain develops. In other patients, you will not get restriction both in active and passive. You might get restriction in either passive or active. In this, both can be restrictions. So, and in range of motion, restricted, you can consider as frozen shoulder, and the symptoms must be stable. It is not like that the patient said, today I have pain, tomorrow I don't have pain, the third day pain increase, fourth day pain decrease. The patient pain must be stable at least for 1 month, or it can increase also. So this, very important criteria to rule in and rule out, to which patients have frozen shoulder and which patient doesn't have frozen shoulder. So rule in for frozen shoulder is, that means the patient age between 40 to 65 years. Even they called it, frozen shoulder, 50 years old frozen shoulder patient. They have given the name also like that, because it's mostly you will see in these age groups, frozen shoulder, 40 to 65 years. And it is like slowly progressive pattern of increasing pain and stiffness. These type of, that means stages of the, frozen shoulder, like freezing, frozen, thawing phase. So it's pain and, stiffness increasing. Then pain which limits sleep and ADLs, that can also, rule in for frozen shoulder. But, what is the rule out? Rule out will be external rotation. When you do passively, you will feel the hard end feel. What is the end feel in frozen shoulder? It is in starting stages, it is mostly muscle spasm, end feel or ladri end feel. But it will not be bone to bone end feel. If you are considering that, consider it might be osteoarthritis or it might be posterior dislocation. So you should always check when you are checking frozen shoulder patient, what is the end feel. It gives you idea patient is fitting exactly under frozen shoulder or not. And when you check the patients, the glenohumeral movements will be restricted mostly in all planes, but the mostly affected movement will be the external rotation. So how you can differentiate with other pathologies, when you tell you do the patient external rotation, and then you tell the patient to do external rotation at 90 degree also, both will be restricted. It is not only the 0 degree without abduction, it is restricted, and this is not restricted. When you feel the patient is restricted in this, and suddenly they will be able to do this, that means they might be having some tendinitis, they might be having some bursitis, but they are not frozen shoulder patients. Now the cervical origin pain, how to exclude? Just the neck, just tell them the just normal active movements of the neck. Mostly active movements only will give you idea the patient shoulder pain is coming from the neck or not. But still some patient you can add the resistive movement of the neck, the Sperling test, to rule out the cervical radiculopathy. You just have to tell the patient to do side bend, then gives axial compression if the test is positive, and then you can further, if you feel that the patient pain in radiation, it is due to in the dermatomal pattern, then you can do the upper limb tension test also to further diagnose. But active and resisted only will give you idea it is shoulder related problem or it is cervical related problem. Then if the patient have history of trauma or something, rule out through first X-ray, and this is important test, to rule out trauma patients. If the patient is coming to you, but they have reduced already, might be patient is coming to after 1 week, the pain is having, you might be suspecting because the Okay, in this also the patient's symptoms might be mimic with the rotator cuff. So how to rule out that? Okay, with the apprehension test. Okay, I need one model. On. Okay, light. Yes, supine. I hope everyone knows supine position. So yeah, comedy. So I'll show. Okay, on just move this side so that everyone can see. So mostly, okay, if you see the okay orthopedic OPDs, they will do apprehension test in standing, but that is not the usual test. Okay, how you do apprehension. Okay, so it has to be done in the okay supine position. Take the arm, okay, into abduction, then into external rotation. Patient who is having a okay mostly dislocation, okay, or okay any kind of dislocations, not rotator cuff related shoulder pain. If you have dislocation, that means you are excluding this trauma. Okay, so they will not allow you to go full external rotation. They will apprehend because of fear of dislocation. Okay, so but this is half test. Okay, normally people will think I am doing this, but I am not doing. That is not a full test. You have not finished the test. You have to confirm the test by doing relocation. Okay, so what you have to do? Okay, in the humeral head. Okay, and see that you don't. Okay, use this area to press the humeral head. If you press this, your symptoms will cloud. Okay, that means you are poking the patients. So patient will not able to properly okay give you positive results for this. You have to use okay the cup. Okay, then do this and then do the external rotation. Patient will feel comfortable. Okay, he will allow you the movement. Okay, then again reconfirm and maintain this external rotation. Okay, while if you are releasing the okay external rotation should be at the end range maintained where the pain was developed. Then release this, the patient pain reproduce again. Okay, so again they will feel fear of apprehension. That means it's a positive test. Okay, to exclude trauma. That means you don't have to go with these type of patients further assessments. Thanks. Now, okay, comes to the main how to assess the rotator cuff related shoulder pain. You have differentially diagnosed all, you have done all exclude other things. Okay, so in this also combination test have marginal accuracy. Okay, that's why you have to add along with that other test like called symptom modification procedure test also. If all the 5 tests okay is positive, that means it's a very high accuracy the patient have rotator cuff related shoulder pain. So now we are going to okay first I will show you the 2 symptom modification tests, then I will show you Nair also, Hawkins also, and job test also. So first it is audible. When the patient is having empty cancer, first test is the scapular retraction test. If the scapular okay kinematics while changing the patient pain is reducing or not. So you can perform this test also to okay give your rehab idea for that. So So what in this test, what you have to do first you have to tell the patient to lift the arm, okay, in sagittal plane, okay, and ask there is a pain or not. And then if the patient complains no pain, then take it down. Then tell the patient to take in frontal plane, okay, into abduction full. The patient complains in this plane pain, okay, then you have to treat on this plane. If the patient doesn't complain, even this okay plane there is a pain and all, then you have to tell the scapular pain plane, the patient to lift arm, take it down slowly. If the patient complains in this plane, then you have to perform the test in this plane only. So whichever plane the patient is complaining plane, okay, in that plane only you have to perform the test. Okay. So suppose the patient has complained about scapular plane I have pain, but other planes I don't have pain. So then what you have to do? You have to okay take your arm, okay, make posterior tilt, okay, and then external rotation of the scapula, and then the patient to perform the same movement. First I have shown you the scapular okay retraction test. Okay, now I am showing you the scapular. So first test, okay, it is like you have to tell the patient, okay, to do the movement in all the planes, whichever plane the patient is having pain, okay, the test you have to perform in that plane only, okay. So suppose it is okay in the frontal plane, so then you have to perform the test in frontal plane only. What you have to do, as I already told you, there are studies which has proved, okay, posterior tilt and external rotation is the main okay factor which is developing okay to rotator cuff. So that means you are supporting okay passively the external rotation okay along with external rotation posterior tilt, and then you are seeing that that plane is getting pain free or not. Suppose before that the pain was 7, after doing just supporting this test, it's a assistance test, okay. So while assisting, the patient pain gone down to 3. That means it's a positive test. The patient might have rotator cuff related shoulder pains. Okay. Then the next test, assistance test. In case okay the patient doesn't have a okay upward rotation proper of the scapula, okay, so that also okay leads to pain like rotator cuff related shoulder pains. So you can check okay in your rehab you need to train your upward rotation or not. That means the serratus anterior is working properly or not. So you can do this test also. Again you have to check all the movements first in okay sagittal plane, then in frontal plane, okay, then in scapular plane, whichever plane the patient is complaining pain, there only you have to perform again this test. So what you have to do? This is the inferior angle of the scapula. So while performing the movement, okay, like in scapular plane, you have to assist, okay, the scapula like this. If the patient pain again, suppose there was 6 or 5 pain, okay, score, now it is gone down to 2 after doing this. That means the patient needs upward rotation rehab, okay. So be doing proper, you are not going upward rotation like this. You have to just okay hold the inferior scapula, okay, and then push it outward, straight, okay, not upward for assistance. Okay, thanks. Okay, so this is another test, symptom modification procedure. Okay, it is also you have to check first the patient in all the planes, which plane is patient is having pain. In that plane, you have to assist the okay upward rotation, but in a translation way. Don't assist okay like full movement. That means that will not show you positive results. Okay, we are going to practice all that. Okay, including Nair, job, okay, and Hawkins test. Just one model. This is very important because these all 5 tests will give you clear picture. Okay, patient is having rotator cuff related shoulder pain or not. If all these are positive, you don't need other okay things to do also. You don't need MRIs, you don't need other scans also, but all has to be positive. Okay, so as you can see in the pictures, okay, which I videos all that I explained you, just okay brief that. So first you have to check okay all the movements, whichever the plane the patient is having movement pain, that plane only you have to do. So first was okay posterior tilt, okay, along with that scapular, okay, external rotation. So posterior tilt maintain just above the spine of scapula, and then the external. You can't go straight, so you have to go for external rotation diagonally, okay, and then tell the patient to do that movement. If it is pain is got reduced in that plane, that means the test is positive. Another test was, okay, so you can come. Going to show you about. I don't know. He is happy to remove. Okay, you can remove. No, he is shy. Okay, so I can show like that only. So another test was, okay, scapular resistance test. It is called scapular modified test also. So same thing. You can tell the patient to do all the movements, whichever plane pain is producing. That pain only you have to do the test. So this test. So you have to hold the, okay, inferior angle of the scapula, and you have to just glide it like outward. Don't assist like this. Okay, assist, just glide it outwards. Okay, if this is also positive, that means you have accuracy very good. Now comes to Nair, okay, test, Nair test, okay. It is given, okay, by Nair, which has given the definition only, but this has alone, this is mostly very weak evidence. That's why they have considered all these tests include only will give you idea the patient is having rotator cuff related shoulder pain or not. Then in this test, you have to stabilize the scapula, then arm, okay, internally rotated, and take the arm passively to full. If the patient complains of pain, okay, anteriorly, that means it's a positive sign, near impingement. Then the Hawkins-Kennedy test, okay, take the arm into scapular plane, okay, then take the arm into internal rotation suddenly, okay. If the patient complains pain, but there are different, okay, tests in this also. If you want to do what type of structures are involved, okay, you can check. Instead of scapular plane, you can go to, okay, adduction also, and then also you can tell, okay. If you want to do, it might be subcoracoid, okay, involvement, it might be subdeltoid involvement. So based on that, you can design this test. But what has given by Hawkins, that is in scapular plane, okay, you just have to do internal rotation like this. If it's positive, again, okay, it's a positive sign. Then the Job test, another name for Job test, which everyone knows. Now, empty can test, okay. So what you have to do, okay, arm into, okay, again internal rotation in scapular plane, take to 90 degree, tell the patient to resist the movement, just push up, okay. If it's causing pain, again it's a positive test. Thanks. So all these 5 tests have very good accuracy for, it's okay. Okay. So all these 5 tests has very good accuracy to diagnose rotator cuff related shoulder pain. But before that, you have to exclude all the differential diagnosis which I have told you. If you have not excluded, or if you have not taken the history proper, okay, you might be not, okay, having proper, okay, diagnosis. Then this is very important to design your rehab, okay. So tissue irritability classification. So patient, you can classify based on this and design your rehab plans. So if the patient is having high irritability, moderate irritability, or low irritability, so that means the patient is having, okay, in high, night pain and rest pain will be consistent. Okay, as I already told the patient who is having too much pains, definitely they will be having pains in most of the time. Okay, and in moderate, it will be intermittent. That means some of the activities patient is having pain, some of the activities, okay, patient is not having pain. Okay, and in rest also, night also, sometimes they will get, sometimes they won't get. Okay, and in low irritability, mostly these night pain and rest pain will not be there. Then pain levels also mostly will be in high. It is considered some people having 8 also. It is not only 7, but okay, as a point 7 to 10. Then 5 to 10 in moderate, and low it is 3 to 10. Then pain in range of motion. So 3 difference you can decide how to decide patient is having high irritability, okay, moderate and low. Okay, not only through, okay, VAS scale, you can check also. Okay, then in this pain mostly starts when you're taking the movement, tell the patient to do active movement. Pain will be starting before reaching end range only. Okay, that means it is considered as high irritability. Then pain at reaching end range of motion. Okay, it is considered as moderate irritability. When the pain only when you push over pressure, then only the pain is developing. That means the pain is end range. That considered as low irritability. So then the active versus passive range of motion. Active range of motion, okay, less than passive due to pain. That means they have, okay, range of motion active less, okay, compared to passive in high irritability. Intermittently, moderately in patients, both will be same. Even passive will be that much, active will be that much. And low means, okay, no pain in both much. Even if you do active, passive, it might be very mild or it might be not there. As I already told you, okay, if you diagnose properly rotator cuff related shoulder patient, there is no role of imaging in this. Okay, but criteria has to fulfill. Okay, that means you should differential. There is not large rotator cuff tears patients. This only small tear. Okay, rotator cuff, okay, related shoulder pain patients means it's an umbrella term. Okay, mostly it considers impingement also. It considers bursitis also. It is called tendinopathy also. It is like a patellofemoral syndrome in the knee. Okay, so it's a term which is given because they are not able to rule out what is the contributing factors to cause this. That is why they have called all these entity, okay, rotator cuff related shoulder pain. So, but there are some criteria which they have maintained, like large rotator cuff tears. This doesn't comes under, okay, rotator cuff related shoulder pain patients. So you have to exclude that first. But other pathologies to rule out, you require scans. Now, as I already told you, okay, scapular, okay, movement disorders of the scapula, which is the most important. That's why we should know little bit about scapular dyskinesia also. Okay, so scapular dyskinesia is what? It is just, okay, abnormal movement of the scapula. Okay, so you have to check both sides. You can't check in one side and telling abnormal. You have to check both sides. So lot of evidence suggests, okay, abnormal positioning mostly leads to rotator cuff related shoulder pains. And also, as I already told you before, the lot of research has done increased upper trapezius activity and decreased lower trapezius and serratus activity leads to scapular dyskinesia. So there are three types in this, okay, which you have to, mostly there are other types also, but this is the main three types which you have to see in the scapular dyskinesia patients, okay. So if somebody is ready to expose, I'll show you, otherwise I have to explain like that only. So it's up to you. Some model. Good. We have all have studied like that only. How will study the body without showing? 4 minutes. I'll finish this only then. Can you move the shirt? You can put the, where is it? Slide so that they can see that. Okay. Come this. So just tell the patients, okay, to lift your arm, okay, slowly upwards. But only thing, okay, the scapular dyskinesia patients, you will not see, okay, while taking into flexion, you will see in eccentric motions only downward, you will see the scapular wingings, all that, okay. So take the arm and tell them to bring it slowly, okay, slow, bring it down into, yes, take it down, take it down. You can see in this anything. What is the difference you will find? What is happening? Which border is this? So what type is this? So he is also having type 2, okay, on the left side, okay, scapular dyskinesia. So, and So type, okay, 1 will be, it will be like medial border will be, okay, coming out, okay. Type, okay, sorry, the inferior border will be coming out. Type 2 will be medial border. Type 3 will be, okay, superior border. So, but in this, you also have meant scapular, you have to work on your scapular, okay. So, this is the way, this is like a visual observation to see the scapular disc kinesia, okay. So, mostly you will find, okay, the type 1 more, type 2 after that, and type 3 less, okay. Type 1 is, okay, mostly you will see lot, mostly in overhead athletes, all that you will see that, okay. So type 2 is very common in mostly sedentary, all that people, you are working athlete or not? See, sedentary, okay. So that is what I'm telling, okay, thanks. We have to stop. We have to stop for inauguration. So after inauguration, again we'll continue. Okay, further things.
It was a great session, sir. Thank you for that. As we didn't get time to introduce ourselves, I, Dr. Benjamin.
And I'm Dr. Fatima, will be your host for the day. And now we request everyone to gather in Hall A for the inauguration ceremony. After that, we request everyone please be on time at 11, sharp 11, gather back here. We will resume the session. Thank you.